one regimen right now that is a standard of care is the combination of two checkpoint inhibitors, ipilimumab and nivolumab, based upon the CheckMate 214. I want to stress that the reason for FDA approval, in fact, the label of that regimen really actually speaks as to patients with intermediate risk and poor risk disease, right? Comparing that with sunitinib, that's number one. Survival improvement was the primary endpoint. That's what we got a label. The second trial was actually the Keynote 26, which is again a trial looking at the combination of axitinib and pembrolizumab, a PD-1 inhibitor, in all comers, meaning good risk, intermediate risk, and poor risk. So basically, it was all comers, not specifically to one patient population. That data also demonstrated a significant survival improvement compared with sunitinib, which was the control arm in that case. The bigger question when those two trials came about was, how do we treat patients? Do I use ipi-nivo, or do I use oxy-pembro? And the truth of the matter is you're going to find two camps of people in America right now. Those who truly believe in immunotherapy and that all patients, regardless of risk stratification, should receive immunotherapy base, and this case would be ipi-nivo. And the camp that will say that you have to actually use a TKI at front along with immunotherapy just by virtue of a rapid overall response and also a PFS improvement, something that the CheckMate we didn't see just by virtue of IO and IO combination. Now, what those two trials, didn't really actually expand too much and didn't actually allow us clinically to define is the PRO data and the quality of life as to which agent will actually, or regimen should give you a better quality of life. So you can talk to a patient, tell a patient, not only you're likely to live longer, we're likely to delay progression, we're likely to delay growth and or lead to responses where they are partial or complete responses and durable responses, but how are you going to live through it? Right now, CheckMate comes and complicates the situation a bit more because now we have another TKI. In this case, a TKI that is a bit, people perceive cabo as a bit more toxic compared with axitinib, but clearly the combination of cabozantinib and nivolumab, in the CheckMate against sunitinib, yet again, demonstrate a significant survival improvement, delay in progression, and yet again, another sort of series of side effects that are a bit different when you compare the two trials, although hard to do because those two trials cannot be compared head to head. But nonetheless, a bit of a difference in side effect when you compare cabo against axitinib, if you will. When you look at the side effect profile of the arm that contain pembro on the axitinib pembro data or Niner with nivolumab, you see roughly the same, to be honest with you. But I think the bigger key differences between the two trials is the true side effects of cabo against axitinib, and how do you titrate axitinib? How do you titrate up or down cabozantinib? I also remind the audience that cabozantinib was not given at the full dose from Meteor, which is 60 milligrams per day. It was actually given at 40 milligrams per day. So hypertension, hand-foot syndrome, diarrhea, and fatigue remain probably the most striking side effects that you may see with cabo as a single agent and in combination with nivolumab. And if I may allow to lump also the data from the CLEAR data, which is the randomized phase 3 trial looking at lenvatinib plus pembrolizumab against lenvatinib, everolimus against sunitinib, with the primary endpoint of comparing the outcome of len-pembro against sunitinib. Yet again, another fantastic combination that led to a PFS improvement in favor of lenvatinib and pembrolizumab compared with sunitinib. Also with a bit immature survival data, but it's still in favor of the combination lenvatinib and pembrolizumab. Yet again, another series of side effects that are a bit different to what you see with cabo-nivo and also with oxy-pembro. So when you put all these three regimens, even though len-pembro is not approved yet in America, you can see that they're going to be three combinations of TKI immunotherapy against a dual immune oncology approach, which is ipi-nivo against TKI plus pembro or nivo, or in this case, len-pembro. And I think the bigger question is going to be how do oncologists decide, between one or the other? I don't think the fight is going to be, if you allow me to use that expression, between dual IO against TKI. I think that the issue with the TKI combo approach is going to be which out of the three TKIs people are going to be comfortable using. PRO, quality of life, endpoints such as, time to best response, if you will, durability of response, and how many people have complete radiographic responses and how durable they are is going to be the key for us to actually select, if you will, in the prospective management of our patients, which out of those three regimens one would use.